Hello and welcome to this video in which we will run through the recommended approach to intubating patients with COVID-19. It draws on resources available nationally and those developed locally at University Hospitals of Leicester NHS Trust. It is not intended as an intubation training video, and it is not a substitution for hands-on practice or simulation. Airway management should be safe, accurate and swift. Safe for both staff and patient. Accurate in that unreliable, unfamiliar or repeated techniques are avoided, and swift, i.e. timely, without rush or delay. In order to achieve this, we use a COVID-19 intubation checklist. There are 3 parts to the intubation checklist. The clean space check, which is done on the intensive care unit before attending the patient on the ward. A don kit and make ready, and this is done outside of the cubicle or area the patient occupies, and a prior to transfer check.
Okay, so we can go through our checklist. So we're going to assign roles. Sam, are you going to be our...
Yeah, I'm happy to intubate it.
Let's just intubate at the moment, and Sue will assist, and we'll send a third member of the team down as well as backup. Have you emptied your pockets?
Yeah, I'll take my stuff.
I've just got my big hat that I will wear.
Are you both mass fit tested?
I am mass fit tested, yep.
Yeah, I'm
Sam,
good.
you're wearing a hood. Okay. We have full PPE.
Yeah, so I will take the plastic gowns for over the top, we'll put surgical gowns, the disposable ones underneath, and we'll take everything down with us for place from the storeroom.
I've got the visors.
We've got visors.
Fantastic. Have we checked the intubation boxes?
Yeah, so they have been all checked and tagged this morning, so we don't need to do a second check.
And drugs were drawn up today,
I did, yeah. I draw up the drugs I need for that patient.
and they're all labelled appropriately.
Yes.
Fantastic. So we've been through this simulation. We have an intubation plan and an escalation strategy.
Yeah.
Very clear about that.
Yeah.
Okay. And have we discussed how we're going to come back to ITU?
So we're on CBU, so we're going to come into the lifts that are nearest CBU, up around the top corridor, and if we're going into our cohorted bay, we'll come in through the bottom doors.
Good. And the nurse in charge is aware?
Yes.
Good. And we've got a room.
So
Okay.
take round, yeah.
Good. Fantastic.
Okay, thank you.
Please use drugs that you are familiar with and will provide the best hemodynamic stability. Each person attending the intubation should wear 2 gowns, 1 pair of sterile gloves and 1 pair of non-sterile gloves. Ensure that you select the appropriate respirator depending on prior fit testing. Bag 1 contains all the standard equipment for intubation, although with a few important additional items. These are a yellow viral circuit filter, a tube clamp, and a clear plastic body drape to cover the patient with during transfer. Bag 2 contains additional equipment for backup airway plans. And Bag 3 contains further equipment needed for the transfer. You may also need a trolley to help you transport all the equipment with you.
Hi guys, so we're about ready to go and intubate this gentleman. So I just noticed there is a table inside, so we can use it to put our box 1 and drugs and everything. We need to put our PPE kit, so we have everything. We'll start kitting and we'll check each other before when we go in. We'll take box 1, so from inside, if we need any kit from box 2, I will point with number 2. When we have successful intubation and we're ready to move to the unit, we'll need box 3. So I'll give you number 3, you pass us the kit. If we run into trouble and we need help, this signal means call ICU for help. Okay. Is that okay?
Yes.
You clear? Okay. Thank you.
When donning PPE, put on the first gown and sterile gloves. Sterile gloves provide better tactile feel than 2 sets of nitrile gloves. Next, put on your mask or respirator. If using a hood, we have found that putting the belt on first, before any gowns, helps later when doffing after admission to ITU. Now, the second gown and non-sterile gloves. This second set allows for doffing of heavily contaminated PPE before transfer to ITU without the need to re-don additional PPE. Use a buddy system to check each other's PPE. If appropriate, explain to the patient what you intend to do and take consent.
We'll be doing everything we can to look after you, but clearly you're working quite hard with your breathing. So we're going to get you off to sleep and take over the job of your lungs for the time being.
Use the locksip to ensure all equipment is to hand, monitoring attached and functioning, and rolls are clear. Once happy, proceed with the intubation sequence.
We have set up as per the locksip, so mask, angle piece, spiral filter, capnograph, water circuit. We're connected for the monitoring. I've got a size 8 tube ready that I've checked. I've got a tie, a bougie, an LMA 4, and oropharyngeal airway if it's required. Suction and your
I've got section and it's on maximum, yeah?
okay, and I've confirmed the IV access is working. Are you happy with the position? Okay, are we happy to proceed?
Please.
Okay. Okay, so we're going to go to sleep. Right, Mrs. Smith, I'm start getting you off to sleep, okay?
Key points here are that the viral filter is positioned as close to the patient as possible in the circuit. Pre-oxygenation is done with a well-fitting mask via the Mapleson C circuit. Optimal muscle relaxation is provided. A good mask seal is maintained after induction using a VE grip, as shown here, to help contain the viral spread. No ventilation via the face mask is given after induction. The cuff is inflated before ventilating the patient's lungs, and auscultation is not done as this risks interfering with the face mask or hood seal. Plan C is intentionally left out of the airway management algorithm, as this step can expose the team to aerosolization. In the rare occasion where Plan A and B fail, please use the VE grip and low flow ventilation or emergency front of neck access if it is the only option. This escalation should be decided prior to the procedure. After intubation, proceed with the post-intubation checks. Confirm correct tube position with end-tidal CO2 and chest movement. Do not auscultate, as this might interfere with your respirator or mask. Secure the tube and consider placing an NG tube if hemodynamically stable. Ask the runner for bag 3 in order to prepare the patient for transfer. When switching the patient onto the ventilator from the Mapleson C circuit, use the tube clamp to avoid aerosolization when disconnecting.
Okay, clamping.
Start the ventilator only after connecting to the endotracheal tube.
Switching on. And we're ventilating with 100% oxygen.
Place all the contents of bag 1 in the bed so that they accompany the patient to ITU. Having completed the intubation locksip, return to the final part of the checklist to prepare for transfer. There is some overlap of items here. Remove your top gown and non-sterile gloves and clean the still worn sterile gloves with alcohol gel. Dispose of rubbish in the clinical waste bag. Cover the patient with the plastic drape and commence the transfer. After completion, if you have any feedback, please submit it via the email using the QR code on the checklist. This video was made by the Department of Adult Intensive Care Medicine at Glenfield Hospital, University Hospitals of Leicester NHS Trust. Further information and resources for anaesthetists and intensive care staff are being collated at ICM Anaesthesia COVID-19 .org. Additional information about donning and doffing can be found on the government website under Infection Prevention for COVID-19.